Welcome back to my channel, Learn with Professor Janula. If you're new here, don't forget to subscribe and hit the bell icon for notifications. In today's video, we're going to learn about pregnancy-induced hypertension. Let's get started. Pregnancy-induced hypertension, or PIH, means a woman develops high blood pressure only after she reaches 20 weeks of pregnancy. It was not present before. The blood pressure becomes 140/90 or higher on two different checks. There is no protein in the urine and no other signs that suggest preeclampsia. So it is basically high blood pressure that starts because of pregnancy without any additional complications. Let's see about the types of PIH. The first type is gestational hypertension. This begins after 20 weeks of pregnancy when the blood pressure reaches 140/90 or higher. There is no protein in the urine and no signs that the organs are affected. In most cases, the blood pressure settles back to normal within 12 weeks after delivery. Still, there is a chance that it can move toward preeclampsia, so monitoring is needed throughout pregnancy. The second type is preeclampsia. This is a pregnancy-specific condition where the mother has hypertension along with protein in the urine, or hypertension with signs that organs like the liver, kidneys, or brain are affected. It shows that the condition is becoming more serious and needs close attention. Now the third type is eclampsia. This happens when a woman with preeclampsia develops seizures that cannot be explained by any other neurological problem. It is considered an obstetric emergency because both the mother and baby are at high risk. Treatment requires magnesium sulfate to control the seizures and immediate stabilization to protect the mother and the baby. Let's see about the next type of PIH. The fourth type is chronic hypertension with superimposed preeclampsia. This happens in women who already had high blood pressure before pregnancy or before reaching 20 weeks. Later in pregnancy, after 20 weeks, they start developing new problems like protein in the urine, worsening blood pressure, or signs that organs are getting affected. This shows that preeclampsia has developed on top of their existing hypertension, so they need close follow-up and careful management. The fifth type is HELP syndrome. This is a severe and life-threatening form of preeclampsia. The name HELP comes from three major problems seen in this condition. H stands for hemolysis, which means the red blood cells start breaking down. EL stands for elevated liver enzymes, showing that the liver is getting affected. LP stands for low platelets, meaning the blood's ability to clot is reduced. Because of these serious changes, HELP syndrome needs urgent management to protect both the mother and the baby. Let's see about the risk factors for PIH. Women are more likely to develop PIH during their first pregnancy or when carrying twins or more. Conditions like obesity, diabetes, and chronic hypertension also increase the risk. Having a family history of PIH or preeclampsia can make it more likely as well. Kidney problems or renal disease play a role too. Maternal age matters, and women younger than 18 or older than 35 have a higher chance of developing PIH. Let's see about the pathophysiology of pregnancy-induced hypertension, or PIH, in a clear and detailed way. It begins with abnormal placentation, meaning the placenta does not form or attach properly in early pregnancy. Because of this, the blood vessels in the placenta stay narrow and cannot carry enough blood. This leads to endothelial dysfunction, which means the inner lining of blood vessels becomes irritated and damaged. The vessels go into vasospasm, or tightening. When this happens, less blood reaches important organs, causing reduced organ perfusion. To compensate, the body increases blood pressure, which is one of the key features of PIH. The kidneys also get affected, and they start leaking protein into the urine, leading to proteinuria. As the condition continues, more organs become involved, including the liver, brain, and clotting system. So, The whole process of PIH starts from a poorly developed placenta and ends up affecting multiple organs throughout the body. Let's see about the clinical features of pregnancy-induced hypertension, or PIH. Elevated blood pressure is the key feature of PIH. Because the placenta forms abnormally, the blood vessels become narrow and stiff. This leads to vasospasm and poor blood flow to different organs, so the body increases blood pressure in an attempt to improve circulation. This rise in BP is usually the first sign noticed during antenatal visits. Edema, or swelling of the face, hands, and feet, happens when damaged blood vessels start leaking fluid into the surrounding tissues. This occurs due to endothelial dysfunction, which is part of the underlying process of PIH. As the condition progresses, swelling may become more noticeable. Headache and blurred vision appear when reduced blood flow affects the brain and the eyes. The headaches are often persistent, and blurred vision or seeing flashing lights indicates that PIH may be moving toward a more serious stage like preeclampsia. These symptoms are warning signs that the condition is impacting the nervous system. Epigastric pain, or right upper abdominal pain, is related to liver involvement. Because of vasospasm and reduced organ perfusion, the liver becomes stressed and its enzymes rise. This can cause discomfort or sharp pain under the ribs. This feature is closely linked with more severe forms of the condition, including HELLP syndrome. Decreased urine output happens when the kidneys receive less blood due to narrowed vessels. Poor perfusion reduces filtration, so urine output drops. Proteinuria develops if PIH progresses to preeclampsia. When the kidneys become damaged, they start leaking protein into the urine. Stop. Let's see about the complications of PIH for both the mother and the baby. Maternal complications can be serious. Eclampsia is one major complication where seizures develop, making the situation an emergency. HELLP syndrome may also occur, involving hemolysis, elevated liver enzymes, and low platelets. Renal failure can develop because the kidneys are not receiving enough blood flow. The liver may also be affected, sometimes leading to liver infarct, which is damage caused by poor blood supply. Another complication is abruptio placenta, where the placenta separates from the uterus too early, causing bleeding. Pulmonary edema can also happen, where fluid collects in the lungs, making breathing difficult and requiring urgent care. Fetal complications are also significant. IUGR, or intrauterine growth restriction, happens because the baby receives less blood and nutrients, causing poor growth. Oligohydramnios can occur, which means low amniotic fluid levels due to reduced placental function. Preterm birth is another complication because early delivery may be needed to protect the mother or baby. Hypoxia, or low oxygen supply to the baby, can occur if the placenta cannot deliver enough oxygen. In severe cases, stillbirth may happen when the baby does not survive due to lack of oxygen or severe placental problems. These complications show why early detection and management of PIH are very important for both maternal and fetal health. Let's see about the medical management of PIH, starting with controlling blood pressure in severe cases. Blood pressure control is very important because extremely high BP can lead to complications like stroke, placental abruption, or eclampsia. Labetalol is commonly used, and it is given in doses of 100 to 200 milligrams twice or 3 times a day, depending on how high the BP is. Another option is nifedipine, usually 10 milligrams, and this dose can be repeated after 20 to 30 minutes if needed to bring the pressure down. Hydralazine is often used in emergencies, especially when the BP is dangerously high. It is given intravenously in doses of 5 to 10 milligrams every 20 to 30 minutes until the pressure becomes stable. These medications help protect both the mother and the baby by keeping the blood pressure within a safer range. Let's see about the next part of medical management, which is preventing seizures in severe PIH or preeclampsia. Magnesium sulfate, also called MgSO4, is the drug of choice for preventing seizures. It helps calm the nervous system and reduces the risk of a woman going into eclampsia. While giving magnesium sulfate, it is very important to monitor reflexes and breathing, because too much of the drug can slow down the muscles and affect respiration. For safety, calcium gluconate is always kept ready as the antidote. If signs of magnesium toxicity appear, calcium gluconate is given to reverse the effects and stabilize the patient. Using magnesium sulfate correctly plays a major role in protecting both the mother and the baby from complications related to seizures. Let's see about the next part of medical management, which is monitoring both the mother and the baby closely throughout PIH. Frequent blood pressure checks are important to track how the condition is progressing. Since PIH can change quickly, regular monitoring helps healthcare providers adjust treatment and prevent complications. Urine protein testing, along with kidney and liver function tests, is done to identify early signs. Let's see about rest and positioning. The mother is advised to lie in the left lateral position because it improves blood flow to the placenta. Reducing stress and limiting physical activity also help keep the blood pressure stable. Now for fluids and diet. Staying well hydrated supports circulation. A low-salt diet helps control blood pressure. And adding high-protein foods strengthens the mother and supports the baby's growth. Let's see about the nursing assessment for the mother. Nurses check the mother's blood pressure every 4 hours or as ordered, because keeping track of BP changes helps identify worsening PIH. They also assess the pattern of edema by observing swelling in areas like the face, hands, and feet. Checking deep tendon reflexes and clonus is important to detect early signs of neurological irritability, which may indicate risk of seizures. Daily weight monitoring helps identify sudden weight gain that may be due to fluid retention. Nurses also observe for symptoms such as headache, visual disturbances, or dizziness, as these can signal progression towards severe PIH or preeclampsia. Let's see about the fetal assessment in PIH. Fetal movement count is observed to ensure the baby is active and receiving enough oxygen. Reduced movement may indicate distress. Non-stress tests and biophysical profiles may be ordered to check the baby's heart rate, breathing, movements, and overall well-being. These tests help detect early signs of fetal compromise. Nurses also monitor for any signs that the baby is not coping well, such as abnormal heart rate patterns or reduced growth, so timely interventions can be made. Let's see about laboratory monitoring in PIH. Urine dipstick or urine protein tests are done to check for proteinuria, which helps identify if the condition is progressing toward preeclampsia. This is one of the earliest signs of kidney involvement. Serum creatinine and uric acid levels are measured to assess kidney function. Rising values can indicate that the kidneys are under stress due to reduced blood flow. Platelet count and liver enzymes are monitored to detect complications like HELLP syndrome. Low platelets or elevated liver enzymes suggest that the condition is becoming more severe and needs urgent attention. Let's see about the timing of delivery in PIH. Immediate delivery is needed when the mother or baby is at serious risk. This includes uncontrolled severe hypertension, eclampsia, HELLP syndrome, pulmonary edema, or DIC. Delivery is also advised if the baby shows growth restriction with abnormal Doppler findings, or if the pregnancy has reached 37 weeks. In these situations, ending the pregnancy is the safest option to protect both mother and baby. Let's see about the nursing diagnoses related to PIH. There is a risk for decreased uteroplacental perfusion because vasoconstriction reduces blood flow to the placenta, which can affect the baby's oxygen supply. There is also a risk for injury for both mother and fetus due to severe hypertension, which can lead to complications like seizures or placental problems. Fluid volume excess can occur because altered capillary permeability causes fluid to shift into tissues, leading to edema and weight gain. Anxiety is another common issue, as the mother may worry about her own health and the well-being of her baby. Let's wrap up here. In this video, we saw about pregnancy-induced hypertension, its types, risk factors, symptoms, complications, and how it is managed. Understanding these points helps in early detection and better care for both mother and baby. If you found this video helpful, don't forget to like, comment, share, and subscribe for more nursing-related topics. Thanks for watching, and see you in the next video.